Thank you all for joining, and I will now introduce today's presenter. Following her medical training at the University of Colorado in 1985, Dr. Wood went on to intern at Hennepin County Medical Center in Minneapolis, Minnesota, before completing her residency at the University of Utah Medical Center in 1988. She then completed her fellowship at the University of Colorado. Dr. Wood returned to the University of Colorado in 2022 as a professor of medicine after 25 years at the University of Vermont, and she currently serves as the co-director of the Hereditary Cancer Program. Dr. Wood is an active clinician and researcher. Her clinical focus is caring for individuals with breast cancer or at risk for cancer. Her research program focuses on breast cancer biomarkers and mammographic breast density. A separate area of expertise or investigation is in the area of cancer genetics, focusing on the use of cancer family history and identifying new models for cancer genetic counseling and testing. Thank you, Dr. Wood, for being here with us this afternoon. I am going to stop sharing my screen and then turn it over to you.
Thank you for that kind introduction. And I think I probably should add this field of multi-cancer early detection to my areas of interest. I was talking to the team a little bit before we hopped onto this meeting that this is something I've come to a little bit later in my career, but it seems to be really a big focus for me. I'm going to hopefully have some time at the end for questions, but I think if you want to pop questions into the chat or raise your hand and ask questions, I think we can make this fairly informal. I'm in presenter mode, correct?
Yes.
Okay. Well, first I have to see. Okay. So today, what I would like to do is talk about what we know about multi-cancer early detection testing. There have been a couple of studies that I'm going to share with you on average risk populations. And then there are some studies, including one investigator-initiated trial, which we were doing here, that will focus on high-risk populations. And that's really where we're going. I think sometimes it's nice to really start with a patient just to sort of focus on our discussion. This is a 55-year-old woman who's worried about her cancer risk. She has a medical history that includes a 20-pack-year history of smoking, but she stopped 5 years ago. Her body mass index is 31, which unfortunately characterizes her as obese. Her family history includes a father with pancreatic cancer, diagnosed at age 55, and a paternal aunt with ovarian cancer at 45. She herself has undergone genetic testing, which is negative or inconclusive because we don't have results regarding her paternal side of the family. Her cancer screening is up to date for the screening that we have available to us today for breast cancer, colon cancer, lung cancer, and cervical cancer. She's worried about developing pancreatic cancer or ovarian cancer, and she's heard about these multi-cancer early detection tests. So she's asking her primary care provider and us, should we evaluate her with an MCD test? Today, we have several cancer screening recommendations for average risk individual. These offer testing, which starts at a variety of ages. It's done at a variety of intervals with a variety of techniques, which range in invasiveness, everything from a blood test such as CA-125 to colonoscopy. Testing for these cancers is associated with high false positive rates and low positive predictive values. There are significant issues of overdiagnosis and potentially overtreatment, and there are disparities in both access and adherence to these cancer screening. These cancer screening these cancer screening for which we have breast, colon, lung, prostate, and cervical will actually identify less than 50% of all cancer cases, whereas more than 50% of cancer deaths occur in types of cancer with no recommended screening. Advances in genomic technology have allowed the possibility of testing for multiple cancers at one time through a single blood test. Back in 2023, there was a published systematic review that looked at all the studies on this subject. They were largely case cohort studies. They found a specificity of multi-cancer early detection tests of greater than 75%, with a median sensitivity of 75%. What they also identified is that the sensitivity of these tests increased with stage. They were much better for stage 3 and 4 than they were for stage 1 or stage 2. And the sensitivity seemed to be highest for liver cancer, interestingly. Today, many companies are developing these tests using, as you can see in this middle panel, a variety of different technologies. These tests that are being developed detect anywhere from 3 to more than 10 cancers. Right now, we have prospective studies for 2 of these multi-cancer early detection tests. And I'm going to really focus on the tests that we have looking prospectively. And I'm going to start by talking about 2 prospective studies in asymptomatic average risk individuals. The first uses the CancerSeq test, which looks at both biomarkers as well as circulating ctDNA. This test uses a combination of PCR to detect driver mutations and also validated biomarkers such as CA125, CEA, CA19-9, which we associate with pancreatic cancer. Let me just back up for a sec. They run this algorithm, and that gives them a probability of cancer. They then put this into a separate machine learning algorithm, looking at 31 additional serum proteins and patient gender to predict tissue of origin. So when you get this blood test, if it either tells you that you don't have cancer or gives you a probability of cancer and a tissue of origin. In their case cohort study, they found an area under the curve of 91%, looking at sensitivity and specificity, which is quite good. This analysis was done on 1,000 cases and 812 healthy controls, with a sensitivity ranging between 33 and 90% and 98%, and a tissue of origin accuracy between 39 and 84%. You can see here that the accuracy was much higher for some cancers that we don't really have good screening tests, and much lower for cancers that we do have good screening tests, such as breast, lung, and colorectal. The prospective test was called Detect-A. It was a test of 10,000 women who ranged in age from 65 to 75 and presented for their annual mammograms. It was done at 18 sites associated with the Geisinger Health System back east. They enrolled between 2017 and 2019. Here's the protocol on the right. Participants got a baseline test. If it was positive, they had a second confirmatory test to rule out certain things that that we know can complicate the test results. And then if it was still positive, they went through a PET-CT, and the results were then given back to patients. And then they were reassessed at 12 months. There were a lot of safety features embedded across the study timeline. And what they found, their final enrollment was over 9,000 participants. They had 490 with a positive baseline test, and 134 had a confirmatory test. 64 of those 134 had concerning imaging, and they found only 26 cancers. So let's go back. Almost 10,000 patients to find 26 cancers. And only half of those were early stage cancers. So that gives them a positive predictive value of 40%, sensitivity quite low at 27.1, specificity. So if they told you you had cancer, there was a pretty high likelihood that you did, of 99.6%. However, over the next 12 months, they had an additional 24 cancers detected by standard of care screening, and 46 participants presented with symptoms that then resulted in a diagnosis of cancer. So they did pick up 26 cancers. Half are early stage, but another 70 cancers developed over the next year. This test is now being marketed as a one test for 6 different cancer types run by, I think, 2020 Gene Systems. The next study I want to talk about is the Grail-Galleri test. This test uses whole genome sequencing for a methylation pattern to identify, again, tissue of origin in a positive test. Their clinical validation case cohort study, much like what I said before for the other test, included 5,000 participants. The primary aim of this study was evaluation of test performance for cancer signal detection. In this case cohort study, they had an overall sensitivity of 51%, which again increased by stage, and an overall specificity of 99.5 with a false positive rate. So they called somebody as having cancer, but they didn't really have cancer, of 0.5%. You see here that they had low sensitivity for breast cancer, but as we saw in the other test, high sensitivity for ovarian, pancreas, liver, and esophageal. This prospective study looked at MCED testing using the Grail-Galleri test in a real-world setting. The objective was to assess extent of diagnostic testing required to achieve diagnostic resolution for a positive signal. So how long did it take them to actually find cancer if it was there? To look at test performance and then participant outcomes and perceptions. They enrolled 6,200 participants at 15 institutions. Eligibility included being over age 50, and they had 2 separate cohorts, one with no additional risk factors, and one was a high-risk group, which we'll maybe talk a little bit later about. I can't remember whether I presented this first or second. The risk in the high-risk group, that included smokers, people who had cancer but were cancer-free for more than 3 years, or had a germline mutation in a cancer susceptibility gene, either themselves or in their family. And what they did was they drew blood on participants. If they didn't have a signal, they just assessed them again at 12 months. If they had a signal, then I think I'll show you on the next slide, had a workup for that patient. They also assessed cancer at 12 months. The tests were reported within 15 days of a blood draw, and they completed their accrual in 2020. So this is the workup. So they would identify a cancer signal of origin, and then they sort of scripted the workup. That's also something you heard about the Vanguard study that will accrue here in Colorado. And this is much like what we're going to do in that study, which is give participants or their providers sort of a diagnostic evaluation pathway. They enrolled patients between 2019 and 2020. More than half of the population was high risk. They enrolled over 6,600 patients. 32 were ineligible, 5 withdrew, and 4 were not evaluable. The median age of participants was 63, more women than men. Unfortunately, the majority were Caucasian. Almost 40% were former smokers, so that high-risk population. A quarter had prior cancer. 18% had a gene in themselves or their family. Most of them were up to date with their cancer screening. 99% were up to date with colon cancer screening, and almost 90% for breast cancer screening. In this study, they found a positive signal in 1.4% of all participants. This was higher than in the high-risk population at 1.5%, which represented about 70% of all positive signals. Their positive predictive value by risk overall was 38%, and again, it was much higher for that high-risk population. So here's what they found. They analyzed 6,600 participants. 1.4 had a positive signal. Out of those, they found 35 cancers. So again, very few. 92 had a positive signal, but less, about a third of them actually were determined to have cancer. They found 29 new cancers. Less than half of them were stage 1. This should be stage 1 and stage 2. They did find 6 recurrent cancers. 5 were breast and 1 was prostate cancer. As you can see here, the cancers were more commonly stage 1 and stage 2, more commonly stage 3 and stage 4 than they were stage 1 or stage 2, which is really where you want to be finding something with a blood test. When they looked at how long it took to actually find out if somebody had cancer or not, most participants with diagnostic resolution had at least one test. The average time to resolution, so you have a positive signal, and it took an average of 79 days to figure out whether it was a true positive or a false positive. This was shorter for people who were ultimately found to have cancer. And some patients, they kept testing for almost up to a year, with an average for false positive patients. So they had a positive signal, but they couldn't find cancer, of 162 days. That's a long time to worry that you might have cancer. Here again is just a graphical depiction of this. They had 92 participants who had a positive signal. 35 were true positive. Over the next 1 year, again, just like with the other study, they had 31 people who had standard of care screening and were found to have cancer, and 48 who presented with symptoms. Let's focus then on the higher risk populations. I showed you that there was a high risk population, that previous study, which had a higher signal detection rate and a higher positive predictive value. This Simplify study is actually a multi-center study that was performed in England and Wales, but in 2021. Patients were over 18 and referred for urgent evaluation of symptoms. In this study, they then could provide a blood test, but they weren't given those results. They consented over 6,000 patients, but only 5,000 plus patients were part of their final analysis set. You'll notice that Grail funded this study and the previous study. The results of this study, they found 306 participants who had cancer in this population. They had 244 who had a positive signal in that cancer population. Again, less of them, less than 50% had stage 1 cancer. Their overall sensitivity was 66.3, which is pretty high compared to the other populations, with a specificity of 98.4%. They correctly identified the cancer site only 85% of the time. So this study had a high specificity and similar or slightly higher sensitivity as other studies. Many cancers were diagnosed at sites other than was referred by the symptoms they presented with. And the accuracy of tumor type in this study was only 85%. So it's not really sure how this is going to move the field forward, but it might be helpful if somebody presented with symptoms and you then did this test before an elaborate workup. If it was negative, you had a high likelihood that they didn't have cancer. These tests do leave us with many unanswered questions. So who should be getting these tests? Average or high-risk individuals? What's the proper interval for testing? Most of the studies out there just test it at one time. Should it be annual? Should it be every 6 months? And how do we integrate this with standard of care screening? Who should order this test? Primary care providers are the ones who are often asked to order this test. And who should work up a positive test? And how will MCED tests perform in the real world? So I think everybody realizes that a randomized clinical trial is really needed to determine the clinical utility of testing. Many companies actually talked to the NCI and suggested that they really work to identify, to put together this trial. So they actually developed a framework at the NCI for planning this study, developing a network to carry out the first study and also select the assays that would inform the study. This Vanguard study is a feasibility study, and I'll show you that will then ultimately lead to a randomized clinical trial to determine efficacy of multi-cancer early detection testing. To begin to select the assays that would go into the Vanguard study, the NCI asked Alliance to put together a blinded reference set of cases and controls that they could then use to select assay companies and verify the performance characteristics of their assays. So within Alliance, we recruited patients to provide blood for this collection. We have close to 15, the goal is 1,500 persons with no cancer and 1,500 participants with newly diagnosed but untreated cancer. We have almost 3,000 samples. Specimens are banked at the NCI and then were sent to companies for testing. The companies were blinded to the status of the sample. Did they have cancer? What type of cancer? What stage of cancer? And 2 companies have been chosen for the Vanguard study. In parallel to this Alliance case cohort blinded reference set, a call went out to develop what's called the CSRN, Cancer Screening Research Network. This is funded by the NCI. There is a coordinating center at the Fred Hutch Cancer Center, and the Statistical and Data Management Center is also there. And there are hubs all across the country, of which University of Colorado is one hub, which is kind of cool. This Vanguard study will be the first study that's been done by this CSRN. The design is a 3-arm study with 1 control arm and 2 arms that will have multi-cancer early detection tests. Everybody is offered and encouraged to continue their standard of care screening. If you're in the control arm, you don't get additional testing. If you're in the second or third arm, you get an MCED test, and then we evaluate the results of that test. The objectives of this study is to assess participants' willingness for randomization to get the test or not get the test, to determine adherence to test evaluation and diagnostic workups, to evaluate the feasibility of protocol-defined diagnostic workflows, to determine the reliability and timeliness of blood specimen testing and return of results by MCED companies, and to identify facilitators and barriers to recruitment, retention, and compliance with the focus on diverse participation. Here's the study procedure. This will be done in Colorado at Keefe Memorial Hospital, which is way out east, and Greeley Hospital. So participants are recruited, consented, which can be virtual, and registered. They, at baseline, fill out a survey and get their blood drawn. They're then randomized to one of three arms. One is a shield test, one is an advanced tech test, and the other is no testing. At 1 year, we follow them up with a second blood draw and survey, and we also follow them at 2 years. What I didn't put into this lecture, but I might have had time for, is the evaluation of a positive test. Anybody who has a positive test in this protocol at this site will be then sent to the CARES clinic, where they have a specific diagnostic evaluation clinic. The study is providing scripted algorithms for if it looks like colon cancer or lung cancer or multiple myeloma or pancreatic cancer. And then the diagnostic evaluation clinic will implement that pathway. I want to end by telling you what I'm kind of excited about, which is an investigator-initiated trial. This was first pitched to OCRIST and the IIT committee by one of our fellows, Nikki Balmaceda. As it's finally been approved and she's graduating, Alex Hayden will be doing this study, and the faculty will be myself and Alexis Leal. This looks at the implementation of multi-cancer early detection testing in high-risk populations. The goal of this study is to evaluate outcomes of MCED testing in high-risk individuals and better understand the longer-term impact of testing in these populations. The aims are to evaluate the feasibility of MCED testing. Will people agree to testing? Will they adhere to the diagnostic evaluation? And we're looking at two different patient populations. One, those people who have mutations and are seen in the Cancer Genetics and Prevention Clinic here at AMC. And there's also a separate pancreatic cyst clinic, and we will look at how many positive tests do we get and what is the diagnostic evaluation for these participants. Eligibility for cohort A is a patient who presents to or who is seen in the Cancer Genetics and Prevention Clinic and has a mutation in a high-risk cancer predisposition gene, such as BRCA1, BRCA2, Li-Fraumeni, Lynch, or patients who come to the pancreatic cyst surveillance clinic and have high-risk features as listed here. If eligibility is confirmed, patients will sign consent, which they can do remotely. They'll receive a baseline questionnaire. We will draw their blood. Just as with those other studies, if they don't have a signal detected, we're going to follow them up at, not 6 months, just 12 months. And we're going to look at anxiety and screening adherence and also ask about cancer development. Those who are positive will have the workup based on the tissue of origin. They'll either have cancer confirmed or not confirmed, and then we'll follow them up at 12 months. We're going to look at uptake of testing. That will be an outcome. So how many people who are offered this actually undergo the testing. And then we'll look at follow-up and adherence to the diagnostic evaluation for those who are positive. We'll look at how long does it take to get diagnostic resolution, how long till we either find cancer or say we're not going to find it. And what is the test performance characteristics? At 1 year, we'll look at were they diagnosed with a cancer? Did they adhere to screening recommendations? And what about anxiety and distress of going through this kind of testing? So in summary, I think MCED testing is interesting and exciting screening opportunity. There are, however, many unknowns. How do we integrate this into standard screening? Which population is the most appropriate for testing? And how frequently should this be done? So can we use this today? I don't think so, unless on a clinical trial. I do want to end by going back to our patient who's 55 and worried about her cancer risk. We can talk about this after we take questions, but should we evaluate her with one of these multi-cancer early detection tests? I think the answer is no. I didn't really talk about the cost, but it costs $900 and insurance doesn't cover it. And the low likelihood of identifying an early stage cancer with these tests at this time gives me pause, and I wouldn't just do this for patients, but I would be very much enroll them on a clinical trial. And I'll stop sharing and take any questions you may have.
Thank you, Dr. Wood. We do have a question in the chat. So first question is, do you think the lower level detection of stage 1 or 2 cancers suggests that the tests are more sensitive or are better for detecting later stage cancers, or that the population should be getting tested earlier?
That's a good question. I think what happens, and I didn't really go through this, but in order to have a positive test, you have to deposit some tumor DNA into your bloodstream. So things like ER positive breast cancer don't shed a lot of cells. Things like pancreatic cancer shed things quickly into the bloodstream. So I think it has to do with the sensitivity of these tests. So there's sort of two black boxes of the companies who are developing these tests. One, what is the test they use? And what is the algorithm that they use to have a positive test? And they can set those things anywhere they want. In this Vanguard study, the NCI has asked the companies to set it so they get a higher rate of positivities, and then we'll have to adjudicate all of those.
All right. Next question. I think these next two questions are feeding off of each other, but correct me if I'm wrong. So Dr. Wood, have you heard of pre-NuVu MRIs? So people are able to commercially get a full body MRI focused on preventative care, but it's at least $2,000.
So I certainly have heard about whole body MRIs. We do that for a population of high-risk individuals who carry these TP53 mutations associated with Li-Fraumeni. They do pick up cancers at an earlier, more treatable stage, but these patients are at huge increased risk. I don't know specifically of this company, but I would not recommend that. One of the things that's really interesting about PET scanning is PET scanning has picked up a lot of incidental cancers. I don't know if there's data about that, but I have heard from community people who order PET scans to work up somebody who has cancer, and they find incidental prostate cancer or another mass. So would I get that? No. And so those two questions are together. And I think we need to investigate these. So unfortunately, I think companies are preying on anxiety about cancer development. And I think that, we have standard screening that we know save lives. Does it discover pancreatic cancer or ovarian cancer? Well, no, we don't have that. But I think these tests may be a step forward, but we have to understand them better before we just put them out in the population.
That's really interesting. Thank you. As questions continue to come in, I do have a few questions for you, Dr. Wood. Before today's presentation, we were chatting about how you had presented on a similar topic a couple of years ago for our group. So I'm curious, in the last 3 years or so, what advancements have there been to MSED testing?
So I think there's been an explosion. Probably at that time, the only study that was open or considered was the Alliance study, which we have open here, where we were trying to get this case and case cohort together of patients without cancer and patients at diagnosis. Since that time, the CSRN was competed, and we now have the Vanguard study. I hope that we'll also be able to implement another study that's going out by that company Grail, which is the REACH study that will look at people who are over 60 on Medicaid, offering them a test. So we're currently negotiating. We have been picked as a site, but we need to make sure that we have the resources to be able to do this study. So the breadth of studies that we will have here looking at these tests is like way, way higher than 3 years ago. And that's exciting.
That is exciting and wonderful to hear. I'm curious though, have there been any, what if any regulatory hurdles do MSED tests go through?
So they have to be, so the Grail test will tell you that they're FDA approved, but they're FDA approved as a device. And that's different. Don't quote me on this, but that's different than saying they're FDA approved for clinical use. So we can do them because they have that approval as a device, but we don't really know about their clinical utility. So it's different than drug approval, which kind of gives you a license to do it. I think that hearing their approval, hearing that this is an FDA approved test is a little bit misleading.
Great. And then I just have one more question, and if there are any others, please feel free to speak up. But one of the studies you shared, Dr. Wood, the patient population was, I believe, around 90% white individuals. I'm thinking about how cost prohibitive these sort of tests are. Uh, Is equity in mind at all while we're investigating these tests, or can you speak to that?
Yeah, that's exactly why this CSRN has been created, and the hubs that got grants specifically can accrue rural and underserved populations. So these studies have all been done in white, largely affluent populations. We need to understand how we do this in underrepresented populations. A lot of people have thought, well, this could really be an advance for rural populations or underserved populations who don't want to go through all this testing, but it's cost prohibitive right now. So in order for this to really advance the field, the cost is going to have to come down. Well, thank you. If people have other questions or want to know about the studies we're doing, just go ahead and email me.